This week on the BackTable podcast.
I just say start with something you feel comfortable with. Start with the shorter occlusions that probably can get a glide wire or guide wire through and balloon and stent appropriately. And if you find something that you come across that may be a little bit more challenging, it's okay to phone a friend. It's great to call one of your attendings. It's great to cut one of your partner's opinions at any point, because once you go down that road of placing stents in a patient, you can't take it back. And it becomes much harder.
Welcome to the BackTable podcast, your source for all things interventional and endovascular. You can find all previous episodes of our podcast on iTunes, Spotify, and on backtable.com. Now, a quick word from our sponsor. BD provides clinical education and training through the BD Peripheral Intervention Advanced Healthcare Providers courses. The BD Advanced team offers programs on advanced endovascular management of AV access, emerging techniques in the management of CLTI and venous disease, as well as many different resident programs and peer-to-peer opportunities. Contact your local BD representatives to learn more or visit the BD Advanced webpage. Now, back to the show. I'm your host, Dr. Ally Baheti, coming to you from Tacoma, Washington. My guest today is Dr. Minhaj Khaja, clinical professor of radiology and cardiac surgery at University of Michigan. He's also the Associate Program Director of the IR Residency, and recently he's been named the David Williams Research Professor, which is an amazing accomplishment. Dr. Khaja, welcome to the show.
Hey, Ally, thanks for having me. It's really an honor.
Dr. Khaja and I, we both trained at UVA. He was a couple years older than me. He's been an incredible mentor and resource for me as well. And it's just been so amazing to watch your career flourish in academics.
Well, thank you. It's a lot of hard work. We all do it in different ways, and you have to focus in academia on not just patient care, which is obviously paramount, but also education and keeping up with innovation and research. So it's a lot to do, but I've had great mentors and great mentees along the way, so it's really an honor.
Our topic today is iliocaval reconstruction, but before we get started, I'd like you to tell me a little bit about your path to your current job.
Thanks, Ally. It's a great starting off point. I think many of us who train at the University of Virginia, for example, really enjoy and love vascular interventions. And I think that's what it was for me. When I was looking for a job, I really wanted to do vascular interventions. I was looking for places that had that, and University of Michigan had that in the arterial and aortic world, which is what I was really excited about. And then I came here, and the venous interventions were really they were so challenging. They were so technical. There were so many different types of patients that we had that couldn't help but get involved with it. And then turns out that I ended up really loving that and focusing more on venous and aortic work than arterial.
Amazing. Yeah, you probably didn't think that that's where your career path would be headed when you first came out of training, right?
No, not at all. I thought I'd be doing legs, but in a different way. Here now I'm doing a lot of legs in this way. And it's really challenging, but it's really gets you going. I think helping patients with a disease that I think we know a lot less about in the venous world than we do the arterial world, and sort of working with pioneers, like you mentioned, Dr. Williams, who really essentially was my mentor for my second fellowship and continues to be my mentor today.
I love that you call it your second fellowship. Is it an actual ACGME fellowship that you did after IR, or is it kind of just like your first year on the job was just so amazing?
Yeah, that's a great point. No, it's not an ACGME fellowship, although it probably could be. But I think really your first few years out, you're continuing to learn. We all think that once you finish your training that you're done learning. But my first year, I essentially did a second fellowship. I spent so much time learning from, reviewing cases, and even double scrubbing cases, a lot of them, and actually the aortic space as well as the venous space. And I learned so much, and I also kind of figured out what my passions were from it, specifically some things we may talk about, like anticoagulation and different techniques for sharp recanalization, things that I really enjoy. And I think learning something from someone else new from where you trained is really opens your eyes to a whole nother love that you may have and passion.
Well said. Well said. Let's get into the meat of it. How do these patients usually present to you?
I would say that there's really a lot of different ways. And having worked at both UVA and Michigan, I think it's interesting to see that different practice patterns end up at different institutions sending you referrals. And so I think that we definitely get some patients from end-stage renal disease patients who have chronic occlusions from dialysis catheters and fistulas and grafts. But then also we have so many patients who present with acute DVT. And as we learn more and more about these patients with acute DVT, we know about 50% of them end up having chronic DVT. So I really think it depends on that. When we go to really the nuts and bolts of it, I think we have two different sets of patients that we get. I think it's the in-house patients. Those frequently come from vascular surgery, vascular medicine, hematology, electrophysiology for some of the SVC reconstructions, the PE program, and even other IRs within our own group. Outside of our hospital and institution, it's actually slightly different. We get them from medicine, patients that we get referred that are being chronically followed by outside referrers, and family medicine as well. And then, of course, other IRs and vascular surgeons.
Excellent. Do you have any self-referred patients that come to you for treatment of chronic DVT?
I think now more with IR being a more clinically oriented specialty, people have heard more about this. They've heard more about some of the recanalizations or reconstruction techniques that we use frequently. And then I'll find more and more patients in my clinic who've said, well, I looked you up on health grades, or I looked you up. I typed in Google somebody who does these types of procedures. So we are seeing more of them. Many of them are second referrals, usually from word of mouth, but we do get those. And I think in the older age, we didn't really see those patients. They would have to be referred from somebody you knew or inside your system. But nowadays, I think more and more patients are taking it into their own hands, which is great.
That's fantastic. At Michigan, you have a lot of residents and mid-levels who do procedures for you, correct?
Yes, our mid-levels are involved with predominantly ports and PICC lines.
Sure.
But our trainees are involved in every case that we do.
Do you teach them to look out for these patients when they're doing kind of their regular dialysis line workups and things like that?
Absolutely. I think given how strong our venous program is and all of our trainees really look out for them. But when we have specific types of patients that usually have been blown off in the past, maybe, or people have said, well, there's not really anything that can be done, we make sure during our didactic lectures or during even case teaching while we're doing a procedure, say, hey, this is a patient that maybe we would have forgotten about years ago, and we should really be considering them. I think having trials as well really gets us the ability to talk to trainees and other referring providers as well.
Absolutely. And every time I talk to you about an iliocaval reconstruction, I feel like I just want to remind you that this can be referred to C-track. I think it's a good reminder for everybody working out in private practice too, that those exist.
Absolutely. And there are so many trials that are ongoing right now in the venous space, the acute and chronic. I think it would be a shame not to consider patients so we can further knowledge and figure out what the best interventions or non-interventions are.
So let's just talk a little bit about patient workup. Talk to me about your clinical workup for a patient for a benign venous recan.
So if we kind of focus that to the lower extremities or to the iliocaval veins, I think many patients come in with leg pain or leg swelling. I think the biggest thing in a patient evaluation is being willing to see any patient that may or may not have the disease process you're actually thinking of. So, and I just say that for all the future interventional radiologists out there, that you don't need a diagnosis coming into your clinic. Ideally, you would actually work that up. But to get to your specific question, I think really having a patient present to our clinic usually have a lot of imaging that's been done elsewhere, or they come in with swelling, pain. And generally, I start with an ultrasound of their lower extremities and sometimes even an ultrasound of their IVC.
Now, do you do just a DVT ultrasound, or do you do a venous insufficiency ultrasound?
I generally start with a DVT ultrasound. And the reason for that is that many of the patients that are referred in my clinic are generally within the deep venous obstruction category. If I see them in clinic and I determine that it's probably not a deep venous problem and a superficial, then I generally would go to the next step of getting a superficial reflux study.
Perfect. Okay. Oh, wait, I didn't mean to cut you off. So go ahead. You get your ultrasound, and then what else do you get?
I get my ultrasound, and I actually will really just see them in clinic if they don't have any other imaging. If a patient's being referred by another physician, they frequently have had a CT scan. It may or may not be a venous timed CT scan. It might be an arterial scan, which frequently happens when a surgeon may be seeing them for PAD and they get referred to us. And I'll take a look at those pictures. And I always request all outside imaging because anything can be helpful. Sometimes patients have a spine issue and they have an MR of their lumbar spine and they catch chronically occluded iliac veins on that. The next thing is really when I see the patient. I think the really important thing is to get a thorough history of the patient and look at all of their risk factors for history of DVT, family history, what kind of anticoagulants they've been on, what kind of anticoagulants they may have failed, Is this their first DVT? How long ago was it? Was it provoked or unprovoked? And what sort of interventions or procedures have they had in their past? And speaking specific to iliocaval disease, many patients didn't really know that they had one, but when they were a child, they may have had a heart catheterization because they had congenital heart disease or were in the ICU and had a line. So that's kind of where I start. And the physical exam, I think, is really important. Looking at their legs, looking at their belly, looking for collateral veins, swelling, discoloration, hair loss, and going through what my trainees know as one of my obsessions is the Villalta score and VCSS, the Venous Clinical Severity Score.
All right.
These are both measures that are frequently used in patient evaluation for deep venous disease.
Perfect. So you've got your clinic workup and then you're ready to plan your procedure. Does anything specific in the history and physical lead you to go one way or another when you're planning your iliocaval reconstruction?
The first thing that I want to assess is their anticoagulation, because I'm already thinking about what am I going to do after the procedure. So is this a patient who has had recurrent DVTs in the past and has failed multiple medications, either a DOAC or warfarin or Lovenox, for example, or oxyparin? Have they had recurrent clot after being on these medications? I also want to know the extent of the anatomy that's involved. Is it just the IVC? Is there an iliac vein lesion? Is it bilateral? And I would harp again, as one of my really big obsessions is inflow. And I really want to know what the inflow is going to be at the end of the case or even at the beginning. So looking at the common femoral veins, the profunda, the GSV, and the femoral veins down to the pop. I think that really helps determine the complexity of the procedure, whether I'm going to use sharp recanalization, how long the procedure is going to be, and what are the chances for a good patient outcome in the long run.
That's a really great point. Inflow. Inflow is like the number one most important thing to have have an iliocaval reconstruction succeed, right? Inflow and anticoagulation, right?
Yep.
So I want to talk about a couple specific scenarios I've encountered personally, and you probably have some insights on. What do you do when the extent of the occlusion is below the GSV confluence?
Yeah, that's a great question, and one that comes up all the time. It's one that I faced just on Friday on a patient who had an iliocaval occlusion and had bilateral femoral veins involved. And so really the part of the workup is to look at that chronic DVT ultrasound or the DVT ultrasound, and is to evaluate the vessels that are coming in to your potential stents. And if it's above the inguinal ligament, usually you have enough flow. But if it's below, you have to see what is sort of doing the work. The profunda is usually the vessel that is around. It's got flow in it. It's usually dilated and it's been doing more work. But same with the GSV. The GSV has been carrying extra blood flow through it because usually the femoral and popliteal segments may be occluded. And so when you have to go below the inguinal ligament and go below the takeoff or the insertion of the GSV, I really want to know how the femoral vein just below that is and how the profunda is. Frequently, the GSV comes in higher, almost always, than the femoral vein and profunda confluence. And so you have a little bit extra space there. But you also want to know, do I need to do something to beef up either one of those veins? So I really take a look at that.
That's good to know. So then do you hesitate to stent past that inflow? I mean, these are open cell stents, so they theoretically, you still get GSV inflow or profunda inflow, even if you stented down below them.
Yep, that's very true. I think that earlier in my practice, I hesitated. I saw others in my group, people with more experience, do it. But at first, thinking from the arterial world, you don't want to cover any collaterals. But I think it is different in veins. You want to just make sure that you have recruited enough blood flow into the stent. Otherwise, it's going to fail. And as you said quite eloquently earlier, anticoagulation and inflow are extremely important to keeping these veins open and getting patients good outcomes. And so in the event that I am in the middle of a procedure and I realize that there's not good inflow, I know that I have to do something to improve that. And so if that means stenting below the inguinal ligament, it just changes what type of stent I may use, maybe, but it won't change the fact that I will do that. But I want to make sure that I've seen by venography or by ultrasound where the GSV comes off, where the profunda comes off, and whether I can improve and recruit flow from the femoral vein.
You mentioned below the inguinal ligament, you like to use different stents. I've heard lots of different folks have ideas about this. Feel free to get into specifics of what you like.
Sure. So there have been lots of studies showing that patients have increased pain. We've all encountered it, I think, when you have a high radial force stent below the inguinal ligament. I think many of us focus on potential fractures of these stents, but I think that that's less commonly seen. At least that's what the data shows. But what I do worry about is the patients having pain and not getting a good flow in. And so I found that there are some stents that have a little bit less radial force or a little bit more comfortable. So without having any biases or disclosures regarding these stents, I think that the Venovo and the Cook Zilver Vena actually are a little bit more forgiving below the inguinal ligament. And that was not my practice even 2 or 3 years ago. But now that we've been using the other stents like Well stents for decades, but also the Abre, I find that it's a great stent up higher, but a little bit lower past the inguinal ligament. Patients have that increased inner thigh and inguinal region pain. And again, we want to get the flow into the stent. So we need to stent as low as we need to get good flow. And I think we want to minimize their discomfort afterwards.
That's really good insights. Yeah, I feel the other thing about the venous stent world is you kind of just have to work with what you have, right? With all of the recalls and products taken off the market, put back on the market, what you learned in training might not be what you have in real life. And just knowing the nuances between the different newer generation stents, I think is really, really useful. You get to work at a place where you probably have access to every single stent you possibly want, don't you?
Yeah, I've been blessed in my current career, but also during my training, we had, you'll remember, we had everything.
Sure, yeah.
So we got to try out everything.
Yeah.
And been involved in a lot of studies with everything too. So it's really fun. But I, as you said, I've talked to you in the past and other friends and colleagues in different practices. And, we'll just discuss, hey, what do you do for this? And they'll be like, I've only got X stent, Y thrombectomy device, and Z balloon. And so you have to kind of put it together and figure out what you feel most comfortable with.
Well, I've gotten a little bit off track here, but I do want you to walk me through your basic setup for an iliocaval recan. Do you set these up the same every time?
I have basically 2 flavors, or 3.
Yeah.
One is a native iliocaval reconstruction where there's good inflow.
Okay. Walk me through that one.
Sure. So a native iliocaval reconstruction, I generally have the patient prepped supine, whereas I know a lot of others prep patients prone. And this is another thing that I feel pretty strongly about. We like to come at these occlusions from multiple different access points. And I think sometimes coming from the left side, the left groin, and the right groin is just not enough. So we like to also use IJ access. So in my practice, we prep them supine and we do a bilateral groin extended prep, meaning that we include the upper thigh and we also include medially so that the GSV can be accessed. And I really, again, going back to the inflow, it's important to keep that open. And so I prefer not to stick the common femoral or the mid-femoral vein because it's usually diseased. But if you have a patient that doesn't have any of that, you may stick the femoral veins if it's the common iliacs and IVC. So in general, I prep them that way. It really depends if the patient can tolerate the sedation. But in our situation, we have anesthesia always available, and we either do them under propofol or total general anesthesia. That allows for us to do sharp recanalization a little safer, having these patients asleep and not having to put a transeptal needle or a TIPS needle through, I think helps. So the next step is I get access from all the different points. And generally that's going to be IJ. I put down an 8 French sheath somewhere into the IVC, usually a 45 centimeter sheath. That's really because IVUS, which intravascular ultrasound, the one that we use is an 8 French sheath requirement. So we do that from the beginning. And then I get bilateral groin access again in the GSV. And then I do sort of like a run from all 3 points kind of in the beginning of the case to sort of demarcate what we have to deal with. Once we do that, I put in smaller sheaths in the groin, something that will accommodate a hydrophilic type of catheter. I like reinforced types of catheters. I used to start off with a standard, 5 French catheter, but I found over time that in these chronic occlusions, having a reinforced tip catheter makes your job a lot easier.
So is that kind of like a crossing catheter?
Yeah, the one that I use frequently is the 3-in-1 Navicross, just because it's got a reinforced tip, it's hydrophilic, it's 4 French. I think that it glides kind of through the vessels fairly well. And I use it in a specific way that once I've gotten a wire across, usually a stiff glide wire or straight stiff or angle glide wire, rather than advancing the catheter, I kind of twist it because the tip of it actually allows you to kind of drill through the chronic occlusions. So that is my kind of go-to. I've used the Triforce set made by Cook in the past as well. And it's sort of a reinforced sheath with an inner catheter as well. So all of those, I think, work really well.
Okay, so that's your basic setup. Cross from one side if you can, and then have your IJ access, and then connect the dots, right?
Connect the dots, as Brooke would say. Absolutely. I think another important point is when you have these multiple access points in a chronic venous reconstruction, you perforate potentially with your wire. So careful technique is important, but sometimes it just happens. And when I'm trying for a occluded left common iliac vein for a little while and I'm just not really making progress, you can go to the right side and then start from there. And once you get across from one side, you can really kind of help yourself by ballooning and kind of opening up a channel sort of at the confluence and maybe even come from above. And so I find it really useful to attack these cases in that way.
Do you do them all as single operator cases, or do you always, I guess you always have a trainee that's scrubbing with you, right?
Yeah, we almost always have a resident or what we call fellows as well still with us. Sometimes have a medical student as well. So we have multiple hands on deck. There is the occasional 2-operator, 2-attending case, but those are generally the third flavor of iliocaval recans, which are the redos where there's already thrombose stents in place. Those are a little bit more challenging, and I usually set those up.
I totally want to get to those, but I want to finish about this because I am like a hamster on cocaine and I will lose track of what we're talking about.
Absolutely.
So let me just finish with the benign ones. Can you walk me through your escalation technique for crossing an occlusion in a benign case?
Absolutely. Escalation technique is important. So I generally start out with a sheath, a Davacross type of catheter, and a glide wire and try to go through that way. I think it's important to make sure that you have good back support. So having a sheath right up to the point of occlusion is really important. And that's where I start, is by getting a nice system in place. So stiff wire, having a hydrophilic catheter, and then a crossing type catheter, and then your sheath advanced as far as you can get it so that your catheter doesn't kick back the whole time. After that, if I'm unable to cross, I may try a different type of wire, again, angled versus a stiff wire, and try from a different angle. But if that doesn't work, then I consider sharp recanalization.
All right. What do you start with first for sharp recanalization?
Yeah, so I generally use a transeptal needle. A transeptal needle has a nice angled curve on it. It looks kind of like a TIPS needle, but is a lot smaller. It's got a 21. There's different ones on the market, but the one we use is the BRK needle. It's got a 21 gauge stylet and a 19 gauge needle. It comes in varying lengths. They are kind of long. So again, it depends on where your occlusion is. The needle itself is 71 centimeters. But something like that, or a Chiba, if you're coming from the common femoral and get a 20 centimeter Chiba, that may be able to get you across where you have to go. When I use those, I think it's really important that you have your sheath all the way up to the occlusion before you introduce the needle. So you don't want to go off-roading, as we like to call it. And so I want to get the sheath all the way up, have venograms from both sides of the occlusion, so I know exactly what I'm doing, lock the table, and then go to work. And I think what's really important with these occlusions is that you're using all the tools that you have. Rotational fluoroscopy to make sure you're going in the right trajectory, your venogram, intravascular ultrasound when you do cross, and making sure you're not hitting other important structures. And this is something I did not learn during fellowship and learned during my second fellowship as an attending, was putting catheters in places that you don't want to hit. So there have been challenging cases, including the one on Friday where we put an arterial catheter in because we were trying to cross the May-Thurner lesion. So we put a Cobra catheter into the iliac artery. So we knew exactly where it was. Did a run, pre and post sharp recanalization. We used rotational fluoroscopy to make sure we weren't going too far anterior, whereas we would hit that vessel. We've done cases where we've also we've had a NUS in. Again, these are really complex cases, but you can see the ureter, make sure you're not hitting that as well. So those are sort of my escalation techniques. If the occlusion is really tough, it sometimes can kink or bend or make the BRK sort of just a straight needle. And if you need an angulation, then I kind of move up to a stiffer cannula, something like a transjugular liver biopsy set that has an angled cannula in it. And in some cases, end up using a TIPS needle or colopinto needle itself. Yeah,
that's definitely a hair-raising situation, right? When you have to get the big guns out.
Yeah, and it's definitely not my go-to. I think that I go to sharp recanalization sooner than I used to because I was less experienced and, quite frankly, just scared of doing something bad. But I do think that it's helpful to have all of those different devices and trying them. Of course, for trainees, working with different attendings who try different things is important. And even for myself, finding a sort of easier case, quote unquote, where I can use a different device and figure that out, I think is helpful.
Just to be totally blunt about how to use these sharp recant devices, you poke, and then how do you know if you're in the right spot?
Well, you're hoping that you're in the right spot. I think using the rotational fluoroscopy, it gives you a general sense of where you are, but I think it's not always perfect. And I think it's important to note that when you poke, you're poking in very, very small increments. Like we're talking 2, 3, 4 millimeters at a time until you feel like things are going well. I use an 018 wire through almost all of these devices, unless it's the colapinto needle, so that your hole isn't as big. And as soon as I get across something, I shove the wire up, hope that it goes towards the right atrium and not the retroperitoneum or something else. And then I actually confirm almost 100% with intravascular ultrasound. And so I put in, the reason I use an 018 wire is there's an 018 intravascular ultrasound. There's also an 014, but use that a little bit less because it's a little bit flimsier. And I take it from the point where I know I'm in the vessel to the point that I think I'm out of the vessel and back into the cava or the right atrium. And I do a pullback and I sort of see where I am and want to make sure I have traversed a safe area. Usually it's intravascularly, you just don't see the walls of the vein as well. But it's generally important to make sure and feel confident that you can proceed with the next steps. Of course, a venogram is involved as well.
Wow. So you would rather use the 018 IVUS over an 018 wire before you inject contrast or upsize to an 035 just because it's safer. That's...
I think, yeah. And so I know that might sound strange, but I think that injecting contrast, if I did go outside the vessel extravascularly or I went extravascular and intravascular, when I inject dye, it's going to muddy the view. And so if I inject contrast, I may see all kinds of extra, but it's probably not a big deal because it's in the retroperitoneal space usually, but it makes it harder for me to see what I'm going to do on my next steps. And I feel very confident with intravascular ultrasound. You know where you are at point A and point C, and you just have to make sure that point B didn't go through something critical. So that's how I use it to that benefit. And I keep it smaller. So an 018 hole or a 6 French IVUS is smaller than an 8 or 9 French IVUS.
Sure.
And again, I want to keep my visualization as clean as possible.
Fantastic. So then do you use that 018 IVUS when you're sizing stents later, or do you switch up to an 035?
I'm guilty of using an 035 to follow.
That's what I thought.
Because you get a better field of view.
Sure.
And so I have the liberty of working in academics where sometimes cost is important, but I think that if you're 100% confident that you went through, you have a very good pathway and you do inject dye, then yes, you could save that 018 IVUS. Again, I don't use that 018 IVUS unless I have to do sharp recant. And I think that that extra cost is worth the potential downside to the patient.
Is there a segment length that you're willing to sharp recant? Like what I'm trying to say is, have you ever come to an occlusion and been like, that is too long of an occlusion. I do not want to sharp recant that.
Yeah, I think that's a really important point and one about experience and just knowing your own limits and what's safe and what's not safe. And as radiologists, we know what sort of structures are in the way. And so it depends on where you're doing the sharp recant. But I think around the most common location, which is around the cable confluence, around the sort of renal vein level where IVC filter may be in place, or sort of the Maythorner lesion, I think a 5 centimeter occlusion is sort of, I feel very comfortable with. Anything above that, I want to make sure I'm doing some extra things. Those extra things are, again, putting a catheter in the arterial system to make sure I'm not hitting the renal artery if I'm doing something at that area, or putting it into the iliacs, or just putting it in the aorta, just so I can make sure I know where those things are.
Gotcha. Cool. Anything else about kind of the flavor number 1 recans that you want to talk about?
I think stent sizing and ballooning is very, very important. So pre-dilating before you put a stent in is really important. All the manufacturers recommend dilating to about the same size of your stent. And then figuring out with intravascular ultrasound or IVUS, I think should be the standard of care for these types of cases because you don't really know where your landing zones are. We gestalt with venography, but that's single plane usually. So I think that using intravascular ultrasound, appropriately sizing your stents and making sure that when you're placing the stents that you're placing them so you're that in normal vein on both ends. And that if you have compromised a landing zone on one of the edges, that you probably are going to either need to do something adjunctive, whether it's additional ballooning or extending the stent one way or another.
For sure. Do you get concerned about perforating with your balloon before placing your stent in place? And I guess the adjunct question is, how often do you have to switch to a covered stent?
Yeah, those are always the toughest situations. And it doesn't happen very often, or at least that we know, because of the low pressure venous system. But I do get concerned for jumping straight to a large size balloon. And so one point would be, if I have done sharp reconstruction where the wire didn't just fly through an occlusion, I generally kind of go conservatively. I'll start with maybe an 8mm balloon in the IVC, just through the track that you've created or the recanalized area. And then I upsize to a 12 and then probably get up to a 16. But I go slow and steady because I think if the vein opens up as you balloon it, but if you jump straight to the bigger size, I think that is where I have more risks and you can't take it back. If I put in an 8mm balloon and inflate it, and like you said, it perforated through, I went extravascular or something like that, I have an opportunity to maybe redirect while I'm still not fully anticoagulated, or if I am anticoagulated, to come down on the heparin or argatroban, for example, and then fix it. So I do worry a little bit about that on every case, and that's why I kind of work my way up.
For sure. You brought up the great point of anticoagulation again. I don't think we touched on how you like to anticoagulate during these procedures.
Yeah. So whenever I start the case, I get a baseline ACT or activated clotting times, just see where it is. And then I always do as part of our timeout, I say we'll get lots of ACTs and we're going to give lots of heparin, but we're not going to do it until we have confirmed that we've crossed the occluded areas safely and confirmed it with either venography, rotational fluoroscopy, and in my case, generally intravascular ultrasound. At that point, I give a large bolus of heparin, and I want my goal ACT is around 230 to 250 seconds during the ballooning and stenting. And in general, I administer heparin, and then I check an ACT 5 minutes later. And if it's at a good amount, then if the ACT is in a good place, then I'll ask to check every 15 to 20 minutes. And if it's not in a good place, I'll give a smaller dose and then check again after 5 minutes until I'm sort of at a steady state in that 230 to 250 range. And then we'll check frequently throughout the procedure.
Do you have folks stop their anticoagulation beforehand?
That is a great question. One I hear frequently from trainees is whether to stop any anticoagulation. And if it's an occluded IVC, I like to stop it ahead of time for the appropriate amount. So most of the DOACs are 48 hours, Coumadin being 5 days. And Lovenox is usually one or two doses. And the reason for that is that I feel far more comfortable being aggressive with sharp reconstruction of that 5 centimeter area when they're not on anticoagulation. In general, it's not going to be an issue to stop it for a couple of days. They've got a filter in place essentially. And most of these patients have chronic occlusions.
That's a really good outline for somebody starting with iliocaval reconstructions in flavor number 1. But now let's get to the fun part. What's flavor number 2?
Flavor number 2 is a iliocaval reconstruction with port inflow. And really, that's very similar to flavor number 1, but it requires you assessing your inflow either at the beginning of the case or fighting for it at the end. And that changes how you're going to do things. Because flavor number 1, I prep the IJ and the groins. But in flavor number 2, I prep the ankle veins and the knee veins as well, because I need to build up inflow. And in those cases, at this point, I prep the posterior tibial vein in almost everybody now, whenever I'm doing these types of cases. And I do an ascending venogram as the first step of the case. Because again, I think myself, the trainees, the nurses and techs, all of whom are wonderful at our place, really want to know, is this going to add 2 hours to the end of the case, or are we going to get lucky and are we going to be able to fly through? And so I do ascending venograms by just injecting the posterior tibial vein with a micropuncture kit, and then I squeeze the calf to watch it go up the leg. And then I'll see if the popliteal vein is open, the femoral vein is open, if the profunda is the dominant inflow to the stent, and I carry it all the way up to the groin. So I can either inject a 20 cc with a chaser of saline and kind of move the II as we're kind of going up on each leg, or do it in segments. If it's really bad disease, then I want to kind of look at the knee first, the mid-thigh, and then right at the groin. And really, the rest of the case is kind of the same. It's whether I'm going to do the inflow first because it's so bad, or if I'm going to do the inflow at the end. And my management of inflow is generally either extending the stent or doing venoplasty of the femoral popliteal veins. And I find that it's easier to do it at the end unless it's completely occluded up top. And if it's fully occluded at the common femoral into the external iliac, then I may actually do that first because I don't want heparin on board when I'm doing that. And if I do it at the end of the case, there's lots of heparin kind of going as the stents are already in, and I want to keep the patient anticoagulated. So it's really just that determination of, am I going to fight for inflow in the beginning or fight for inflow at the end? In general, it may add a couple of hours to the case if it's really bad. But if I can't do that, then the stents are going to go down. So I shouldn't do the stenting.
That's such a good point.
So that's actually variant 2, right?
Yeah.
All of that covers flavor 2.
Flavor number 2, man, that's a tough flavor, but I think that's a pretty common one we encounter in practice, and also a common reason why you see the stents go down.
Absolutely.
So, okay, I understand when you treat the inflow at the end of the case, you can use your IJ access. You could, use your GSV access if you need to. But can you walk me through how you treat it from your posterior tibial vein access, kind of like a step-by-step of what you like to do?
Yeah, absolutely. So you hit the nail on the head with the IJ access. If you go from the internal jugular vein, you can go through your stents that you placed and recanalize from above and go all the way down so that you don't have any issues with access from your femoral veins because you can't treat below them. So I generally have a different access point. So that's one. But from the posterior tibial veins, you may think back to your training days of pedal access for arterial cases and doing sort of a safari type procedure for patients with critical life-threatening ischemia, limb-threatening ischemia rather. So generally I put in a micropuncture kit, do the ascending venogram, and then I take a Nitrex type of wire, a long Nitrex, and I advance that wire from the ankle all the way up as far as I can get it. And then if I need to, I again use a Navicross catheter. And sometimes I do that by taking the transitional dilator out and just advancing that. Or I put in a 4 French sheath or a radial sheath in the ankle. The reason I like to keep the ankle sheath small is that has the highest venous pressure in the body. If you think about it, given that these patients have a history of occlusion, they actually bleed worse than the IJ or the groin axis in the end of these cases. And so I like to keep the sheath size small, work my way up, and then I generally tend to snare the wire from above and then do all the work from above afterwards.
That's really tough.
It's time consuming. I definitely believe that's the case. If I can get it all done from below with just a slightly larger sheath size, then I would absolutely do that. But that doesn't happen always.
I'm really excited for the next 5 to 10 years and just to see how we start treating fempop occlusion a little bit differently. Because honestly, that is one of the most challenging things we do as interventional radiologists is manage those patients. You can do the most beautiful iliocaval reconstruction in the world, and then it'll go down a week later because they don't have inflow. So you and I can talk about inflow all day. I know that. I'm sure we have more important things to talk about, like flavor number 3. Hit me with that.
Yeah, flavor number 3 is something that we see far more these days, which is an occluded stent. A chronically occluded stent. They're generally patients that were treated at an outside institution, although could be your own. And I've treated plenty of my patients that I've unfortunately allowed to go down for one of the reasons you mentioned before. And generally, I find those patients to be far more challenging. Their disease is more progressed. They have a much higher Villalta score. They're suffering a lot more. And they've been bounced around from physician to physician or practice to practice and really have a tough time with those. They generally, I think, go down for a host of reasons, with the top 2 probably being inflow and number 2 being anticoagulation.
I knew it. I knew you were going to say that.
But number 3 is probably anatomy or functional, because they may have been the actual lesion that were intended to be treated was missed. Maybe the stent was a little bit too short on a May-Thurner patient, and then it kind of slipped back and occluded. Or you stopped deep in the pelvis where the internal sort of joins into the common and external. That area is usually more posterior. And if you have a stent that ends around that area, it T-bones the vein and causes turbulence. So frequently you're kind of dealing with one of those problems. And anytime you have to come back and do something where there's already a stent in place, veins have been manipulated, it's much harder. For those cases, inflow almost definitely is diseased, whether it was before or not, it is now. And then you have to fight your way through these occluded stents. And you generally have to deal with stents that have less luminal caliber than you would like. So once they're full of chronic clot, you can generally only put a smaller stent inside of them. Although there are newer devices and technologies that are helping you with that, you're sort of constrained to what's there. And so you have to make the best of a somewhat bad situation for the patient first, and then you as the person trying to help them.
Now, just to clarify for our audience, we're talking about stents that have been down for a long time, right? These aren't people who have thrombosed within the past week.
Absolutely. So I would say that this applies only to chronic occlusions. And by definition, I guess that's somewhere in the 3-month and longer region. In the acute and subacute phase, of course, you'd love to be able to thrombolyse or thrombectomize and get them back without adding layers of stents, getting back and then figuring out why they went down. Again, could be one of the top 3 factors. But yes, chronic occlusions that have been down for a long time with chronic thrombus that has sort of created its own network within the stent or around the stent.
Man, yeah, those are really tough scenarios. Do you find that the length of occlusion that you have to cross in those situations is much longer than in your flavor number 1, for example, cases?
Yes. Usually when there's a patient with a stent already in place, you really have to cross the entire stent. Although I would say in the middle of the stent, the thrombus, which we frequently biopsy, is a little bit mushier with the ends, just like in a patient with a fistula that's clotted off, has this chronic plaque. So that is really hard to get through. It's like a very fibrinous plug that sometimes kinks or bends a needle, wires don't want to go through, and you have to work your way through. I will find that more and more these days, we have patients who've had stents for longer and longer, and that chronic thrombus calcifies with dystrophic calcification, which makes it additionally harder because now you have to sort of plow through those. But yes, I frequently see the May-Thurner stent that goes down to the common femoral vein. So it's somewhere in the 16 or 15, 20 centimeter length that you have to burrow your way through.
This is an aside, but I'm actually recording an episode about RF recan tomorrow. So fun fact. Do you ever use reentry devices, like arterial reentry devices, when you're trying to cross these really long occlusions?
I think in the venous world, I have tried almost everything at least once. I think something like a Pioneer device or an Outback, the needle is too soft. It gets kinked. It might break. It doesn't really get through them. Although we've done it again on like sort of a subacute type of patient. In the chronic ones, I think that what we find is that the needles are just not robust enough. They're not directional enough. And so I generally don't. Funny that you mentioned radiofrequency wire. I do use that as a staple and have that ready in patients who have chronic occlusions with stents in. I think there are people who've done great work in RF wire recanalization for native veins. That is something that I'm afraid of and choose not to do. I feel that there's more control with a needle, for me at least, but radiofrequency wire is very useful. And we actually wrote a series of that maybe 7 years ago, of those in chronically occluded stents. And I'm finding more and more I've used laser in these patients as well. It is something that I saw one of my mentors, colleagues, Dr. Engel, do, and it worked. And I thought it was pretty cool. And I've done it in a few patients as well.
Of course, Dr. Engel did that.
Of course, he tried that. I think I tried to get him to use RF wire, and he said, let's try this laser. And it worked pretty well.
Oh, man, that's really neat. That's such a cool thing. Okay, any other escalation strategies you use for the chronically occluded stents?
You know, we have been looking for the right devices and the right techniques and the right tips in order to debulk chronic stents. Because when you have this chronic thrombus, it just forms this brick wall. And when you do get through the brick wall, you can't really break down all the bricks like you can in an acute DVT. And so we have found that I've tried lithotripsy, all the different thrombectomy devices. They all do just a little bit, but not really. And you are left with a lot less room to work. Even if you balloon a 16 millimeter stent, for example, that has a lot of full of chronic thrombus, you balloon it up to 14, or 16, there's still a lot of chronic thrombus that is circumferential within the stent. And you can only usually get away with putting like a 12 millimeter stent within it, or at least that gets to 12. And so you're limiting your ability to get good laminar flow through that. And so what we've recently found there are different devices, thrombectomy devices that are coming out into the market. One of them is the Inari RevCore device. It's truly a coring element, and it's made to be used within stents. I've had the pleasure of doing a few cases with that device, and I found that it almost cleared the entirety of the chronic thrombus.
That's really cool.
I was really shocked and really impressed. I think we still have to reline those stents because there's still a layer, but you're able to put in a 14 or 16 millimeter stent into chronic and subacute thrombus, respectively. So there's those types of devices. Some of the thrombectomy devices are adding on adjunctive devices that go through them that help get rid of more chronic clot. And I'm really excited to see where the field goes because all the industry partners are really excited about this as well. So they're all coming up with a new innovative way.
Very cool. Very cool. Like I said, I think it's going to be a different world if we recorded this podcast 5 years from now.
Absolutely. Or 5 years ago.
Or yeah, exactly. Or even 5 years ago. After the procedure, what kind of anticoagulation regimen do you usually put folks on?
Yeah. So I think it's really important as interventional radiologists who are doing these interventions to know about the anticoagulants and the antiplatelet agents. So as a whole, antithrombotic therapies are really, I think, key for long-term patency of venous stents. And that's been shown in a lot of the literature. What hasn't been shown is what's the perfect combo. And I know some of my research is focused on this, and there's a lot of other people looking into this, and we still don't know what the special sauce is. I think the first answer, though, is the one thing that we do know is enoxaparin is the special sauce for immediate post-procedural thrombosis and reduction of inflammation. So every patient that we do a iliocaval reconstruction on, a fempop or venous stenting that is chronic, not acute or non-thrombotic, we place them on Lovenox. I generally do 1 milligram per kilogram twice daily, and I do it for 2 to 4 weeks. Now, I know patients don't love that, taking an injection twice daily, but the data that we do have that is randomized and that is looked at very carefully shows that the reduction of post-thrombotic syndrome improves significantly after greater than 10 days of Lovenox. So I do that on every patient. They all get Lovenox twice daily at 1 mg per kg. And then we change them to a DOAC after that point. And that DOAC in general, I like to use drugs that have twice daily dosing because I feel that you have no peaks and valleys, but more of a steady state. That's just my opinion. There's limited data to support that. And then I put patients, when they get fresh stents, on Plavix or clopidogrel or one of the other medications that are antiplatelet agents. And I generally do that until I see them back at their second follow-up, which is usually at around 3 to 6 months. And I think that has been shown in some data that there is reduced rethrombosis in these patients, again, with an anticoagulant and an antiplatelet agent on board.
Do you do concurrent aspirin or just monotherapy with a DOAC?
That's a great question. The dual antiplatelet therapy with an anticoagulant is frequently referred to as triple therapy. And I really do that in patients who I feel have the really compromised inflow. Even if I spend all this time in the world trying to improve their inflow, those are patients that I consider putting them on triple therapy. However, that comes with an increased bleeding risk. And so if I have a patient in whom I did sharp reconstruction and maybe had to poke a few more times, I definitely don't start it day of procedure. I frequently get asked by my trainees, hey, Dr. Khaja, do you want to give a loading dose of Plavix tonight? And my answer is always no. I don't give loading doses because of the large dose of an antiplatelet agent because it's got a longer half-life. It's going to be in the system for longer. And if they do have a bleeding complication, I can't get it under control like I can with stopping Lovenox or heparin or something like that. When patients do have bleeding complications, the antiplatelet agent is the first thing I stop because, again, the Plavix, as I tell patients, Plavix or clopidogrel makes your blood less sticky and anticoagulants make your blood flow faster. And so that's kind of how I explain it. And I think that I would rather have it flow better with the anticoagulant on board than the antiplatelet.
I love that little analogy. That's adorable. It makes your blood less sticky. Definitely going to steal that.
No worries. You can steal anything and all is yours. If I may, just a couple other points. We know that inflammation plays a large role, especially in rethrombosis, especially in patients who are having repeat interventions, these patients with clotting disorders or patients who have open ulcers. They have really high inflammatory markers, patients with cancer. And so if you're doing these interventions, you want to reduce their inflammation in another way as well. And enoxaparin or Lovenox has anti-inflammatory properties. So if I had a patient who would tell me, Doc, I'll take whatever you tell me to take for the rest of my life, I would actually pick enoxaparin.
Really?
But most patients don't want to do that. And I know that I probably wouldn't want to. But I do consider other things that reduce inflammation. And there's recent studies to show that statin therapy in patients with venous disease has been beneficial. And there's RCTs ongoing now too. So I actually start my patients on a low dose statin after checking their labs and making sure that they have elevated inflammatory markers. I start them on statin therapy and then also consider venoactive substances like diosmin or hesperidin. So I get ready to throw the kitchen sink at patients, especially the flavor number 3, the redos, which are occluded everywhere. I really want to do the best to keep them open as long as possible while decreasing their bleeding risk.
That's a really great point. That's like you said, throwing the kitchen sink at them because they got to stay open. You mentioned your follow-up in clinic up to 6 months. Do you see them annually after that?
I see them usually immediately post-procedure, which immediately I consider I tell everyone within 2 to 4 weeks. That's usually when some of their discomfort may get a little bit better. We figured out sort of the anticoagulation. And as I mentioned, I usually change them at that point. So I see them in clinic and then I change them to a DOAC. After that, in patients that are complete occlusions that I've had to do, that have flavor number 2 or 3 rather, that have inflow problems and prior stents, I generally see them back a little bit sooner. So 3 months is when I see them. I repeat their Villalta score and I get an ultrasound. And then at 6 months is where I tell them that they've sort of hit their stride. If they've done all the things that they are doing, wearing compression therapy, exercising as much as possible, hopefully having quit smoking if they were smoking, they're taking their anticoagulation, antiplatelet agents. Then at 6 months is when I decide whether they're going to be somebody who's going to probably do very well and require reintervention, or if they're going to. If patients are doing clinically very, very well, I don't actually get any other imaging until 6 months later, where we would actually do a venogram. A catheter-based venogram is what we do at our institution, or a CT scan if the patient really doesn't want that. And I think we're an outlier in that we do catheter-based venograms frequently on these patients because I think we're trying to get ahead of forming in-stent stenosis so that we can treat it accordingly. And I think that would entail changing their anticoagulation around, reducing their inflammatory markers, and keeping their stents open in any way we can. So that's sort of how we go. So 2 weeks, 2 to 4 weeks, 3 months, 6 months, 12 months. And if they're doing great, then a year later. And if they have an issue and they require reintervention, I usually start the clock over.
So they get annual venograms?
Annual venograms for the first 2 years. And then after that, we just move to CT.
That's
CT
wow, yeah.
And ultrasound.
How often do you catch an early rethrombosis or issue with the stent on your venograms?
We've actually frequently see a significant in-stent stenosis. There are patients that we've done a venogram at 3 months as well, but those are usually clinically symptomatic. And we actually see that in the first 3 months or so, they develop as much in-stent stenosis as they're going to, except for in the patients with poor inflow. They just sort of start going downhill if they've already done that 3 months, at which point would trigger me to say, I haven't optimized that inflow. And so given our patient population is more of flavor 2 and 3, so the chronic occlusions with inflow problems and the reduced stents, I end up favoring kind of an earlier clinical assessment and an imaging assessment as needed.
Really important stuff. Okay, well, any other tips you'd like to share for people who want to learn more about this disease or want to start incorporating this into their practice?
Absolutely. I think that it's a really exciting time for chronic venous disease. I think learning the language of patient assessment, learning different tips and tricks with the different recanalization devices is really important. Knowing proper follow-up with anticoagulation regimens and markers for clinical failure are important. But I would say the most important thing is knowing your limits. I know that we all think that these are veins, but bad things can happen. I know they're not arteries, but they require a little bit of more TLC, tender loving care, in case anyone doesn't remember that. But I do think that they do require more hands-on approach to patient management. And I think that when you're starting off and doing some of these cases, they're really exciting to get good flow at the end of the case and opening up patients' veins. That really changes their lives. I just say start with something you feel comfortable with. Start with the shorter occlusions that probably can get a glide wire or guide wire through and balloon and stent appropriately. And if you find something that you come across that may be a little bit more challenging, it's okay to get a phone a friend. It's great to call one of your attendings. It's great to call one of your partner's opinions at any point, because once you go down that road of placing stents in a patient, you can't take it back, and it becomes much harder. And the final thing I would say is using intravascular ultrasound is really, really important and helpful. It helps get away from potential complications, so finding near misses. And it also helps you assess inflow, which is probably one of the most important things.
Awesome. Well, this has been a really great discussion. I learned quite a bit. Thanks for letting me pick your brain. And I'm not exaggerating, Minhaj, when I say that you are like one of the top 10 smartest people I know. You are just a brilliant, amazing person. And I'm so thankful that I know you.
Well, thank you, Ally. It's really been an honor. And, this is all due to mentors and mentees, people we've worked with and on our teams, that it's really been beneficial to help these patients.
Oh, did you want to give a shout out to somebody special?
I totally have to give a shout out, and thank you for that. My son, Musa, has a YouTube channel where he gave a shout out to BackTable Podcasts on one of his YouTube channels. So his YouTube channel is Not MUXA. So NOTMUXA on YouTube. And he's got a video talking about interventional radiology and the shout out to BackTable. So thanks, Musa.
Oh.
And thanks, Ally.
Take care.
Thank you so much for listening. If you haven't already, make sure to subscribe, rate the podcast 5 stars, and share with a friend. If you have any questions or comments, direct message us at @_BackTable on Instagram, Twitter, or LinkedIn. BackTable is produced and hosted by myself, Aaron Fritz, and co-hosts
Chris Beck, Sabine Dong,
Michael Barraza,
and Ally Baheti.
Our audio team is led by Kieran Gannon, with support from
Josh McWhirter, Aaron Bowles, Nick Shellcross,
Josh Spencer. Design and digital marketing led by Brian Schmitz.
Social media and PR by Ann Dang, Manisha Naganathanahali,
and Manveer Singh Sabit.
Administrative support provided by Jamila Kennebrew.
Intro and extra music is Ripperoo by Skeptic Moon. Find us on Spotify or at local live music venues in New Orleans, Louisiana.
Thanks again for listening.